Thank you, Dr. Singh. Now, we had an excellent first part of the day, so let's turn to our second portion. I am going to start by thanking Dr. Atif Tatari and Dr. Jason Cohen, who are our two astute second-year cardiology fellows at the Medical Center Bowling Green today for participating in this second part of the program. Today, they'll be presenting two late-breaking clinical cardiology trials which pertain to patients whom we treat on a regular basis in our clinical practice. The cardiology faculty is very proud of these two fellows from the inaugural cardiology class. Please welcome to the stage Drs. Cohen and Dr. Tatari. And you can see they're already winners.
Okay, good afternoon, everybody. As you guys know, I'm Dr. Tatari, one of the second-year fellows here. So it's a great privilege to give this honor, to give this talk. So I know there's a lot of nervous energy. Everybody had lunch, so hopefully the food coma is gone. So hopefully you guys are awake. So I'm going to try to keep you awake. So I'm going to be talking about a clinical trial here, but the topic of this talk is STEMI. Now, we're faced with the dilemma of, do we fully revascularize them or not? So this is the angiogram of a patient we had, middle-aged Caucasian male who came in with acute chest pain. He had EKG done, which showed acute elevations in the inferior leads, and he was brought to the cath lab. So as you can see here, he has a complete occlusion of his RCA and a STEMI. However, sometimes we're faced with the dilemma, and about 50% of these kind of patients, they may have some other blockages. So when we shot the angiograms of the left coronary system, we see a significant stenosis here in the left circumflex artery. Now, the old practices were not to fix this, meaning we would just fix the culprit artery here, and this non-culprit artery we would just leave alone. So here's a little humor. Make sure you guys are awake. Okay, so I'm going to be using some terminology here, so I just want to go over this, and this is kind of important going forward. So PCI refers to percutaneous coronary intervention, and that's done either with a balloon angioplasty or stent implantation. PPCI is referred to as primary PCI, which is done in the culprit artery at the time of a STEMI. Now, something we do is called FFR, or otherwise known as fractional flow reserve. So it's actually, essentially, the basics is it's an intracoronary stress test done in the cath lab using catheters and wires. So what we actually do is we induce hyperemia, usually with adenosine or sometimes regadenosin, and we check the pressure differences, and we look for a certain value, and if it's significant, then that lets us know that it's we should intervene on it. So I'm also going to be referring to culprit lesions, and that is coronary artery stenosis responsible for STEMI, and also non-culprit lesion, which refers to stenosis that's not responsible for a STEMI. So like I mentioned before, the previous clinical guidelines recommended against PCI of non-culprit arteries, and that was actually a class 3 recommendation, which was harm. So patients, like I mentioned before, patients will have culprit lesions, but 50% of these patients will also have additional other severe stenotic lesions. So we're kind of faced with this problem, in our everyday practice. So there was a recent article in New England Journal of Medicine published on March 30th of this year, 2017, called the Fractional Flow Reserve Guided Multivessel Angioplasty and Myocardial Infarction, otherwise known as the Acute Compare Trial. So I'm going to be going back to this first, but before we go into this, I'm going to go over some other studies and some more backgrounds to help put this study into context. So over the past few years, there have been multiple clinical trials that challenge the concept of treating non-infarct-related arteries. So in 2013, there was a trial called the PRAMI Trial, and this randomized STEMI patients to either getting treated just for their culprit lesion or having preventative PCI, meaning they're non-corporate lesions that had a stenosis of greater than 50%, were treated. So the primary outcome was a composite of cardiac death, MI, and refractory angina, which was statistically significant in favor of the preventative PCI arm, as well as the composition of cardiac death or MI. That was statistically significant as well as refractory angina. Interestingly enough, all death by itself and cardiac death was not statistically significant. So going forward, there was another trial in May of 2015 called the PROG-13 trial. This randomized 214 STEMI patients to treatment of just corporate lesions versus staged non-corporate lesions which were revascularized between 3 to 40 days later. However, they used a different cutoff of 70% for their non-corporate lesions. So the composite endpoint of all-cause mortality, non-fatal MI, and stroke were all individually and compositely not significant. So moving forward, in August of that year, the DINAMI 3 PRAMI multi-trial was done. So this randomized corporate lesion only versus complete FFR-guided revascularization. And ideally, it was done at the time, but sometimes, it was done later in the hospitalization. So the primary endpoint, again, was a composition of all-cause death, MI, and ischemia-driven revascularization. That is actually statistically significant, the composite. The ischemia-driven revascularization was statistically significant as well in favor of complete revascularization. However, the individual all-death and non-fatal MI was not statistically significant, which is an important finding. So this primary endpoint, which is the composite of all threes, was really driven just by the ischemia-driven revascularization. So later that year, the culprit trial came out, and this again had one arm of treating just culprit only versus complete revascularization. So the primary outcome was a composite of death, MI, heart failure, and repeat revascularization. And there was a statistically significant difference in favor of complete revascularization. Again, however, this composite was significant due to the reduction in the need for repeat revascularizations. So in 2000, with all these studies out there, there was, there's trials kind of going against doing it, some that are neutral and some for. So in 2016, there was a meta-analysis done in which they actually used 7 trials. And they compiled that data to try to get a better answer for this. So the significance in this chart here, so this is a composite chart, so the major adverse cardiac events was statistically significant in favor of complete revascularization. And urgent revascularization, again, was same in favor of complete revascularization. All-cause mortality, MI, major bleeding or contrast-induced nephropathy were not significant between the two groups. Now, this is a Forrest plot here, so these are all the trials they use in their meta-analysis. And if you look here on the bottom, you have this diamond shape. So if you look on your little x-axis here, so anything on the left side would favor complete revascularization, while anything on the right side would say that complete revascularization has higher incidence of MI mortality. So as you can see here, it's almost to the left of the land of unity, but not quite. But based on all the composite of these studies, is in favor of complete revascularization. So that brings us to this compare acute trial that I mentioned previously. So this is a strategy of FFR-guided treatment of non-corporate lesions, and they wanted to see if that was superior, if that strategy is superior to treating just corporate lesions. So now this was the largest trial that has been done. A lot of the other trials had about 200, 300. One trial had about 500. So this is a large number of patients, 885, and they were randomized into a 1-to-2 ratio. So 295 were put in the complete FFR-guided revascularization arm, and 590 were put in the no revascularization arm. So the take home from this chart is the major adverse cardiac events was statistically significant in favor of complete revascularization. And the need for revascularization in PCI was also quite statistically significant in favor of complete revascularization. Again, it's important to note that the death from any cause or MI between the two groups was not statistically significant. So with all that being said, I know it's a lot of studies and a lot of information, so I'm going to try to put a bow on this here. So there have been a lot of studies kind of having conflicting data. So now in terms of harm, there was one study, if you look back on the the Forrest plot here. Oops. So here on the Ghani trial, now this is a trial that was actually done, that preceded any of the trials I presented. This was done in 2012, and it wasn't a very good study in terms of the way it was kind of set up, and the primary endpoint wasn't actually detected to really check for MI or any of these kind of outcomes. And in this meta-analysis, it only really contributes about 3%. But that is a trial that it did show an increase in 3-year mortality and reintervention in non-culprit lesions in the groups that were aggressively revascularized. Now, the Product 13 trial showed no difference in all-cause mortality, non-fatal MI, or stroke. And the PRAMI 3, DENAMI 3, PROMI multi trial, and the culprit trials have shown various degrees of benefit. So the Compare Acute trial did show benefit in MACE events. However, this was really due to revascularization, the need for revascularization procedures, and we really didn't have any benefit in MI or mortality. So due to the growing pool of data that show benefit in complete revascularization, our practices of the practice and the management of non-culprit lesions was kind of reevaluated. So this was addressed in updated guidelines done in 2015. So the previous class recommendation was class 3 for treating non-infarct or non-culprit lesions in STEMI. So class 3 was harm. Now it was changed to 2B, meaning it may be appropriate in certain situations. However, it didn't really specify in terms of should it be done right there on the cath table, right after you treat the STEMI, or should it be done the next day, or during that hospitalization, or can it be done as an outpatient? So the guidelines are kind of vague, in that regard. So now, with all that being said, what do we do in our clinical practice? So currently, we do primary PCI of the infarct-related arteries responsible for the STEMI, as per the STEMI guidelines. Now, as for the non-culprit lesions, we generally approach them on a case-by-case basis. So usually in our practice, if we do see a significant lesion angiographically, similar to the one that we saw earlier at the beginning of my presentation, we will usually do a stage procedure, typically later in the hospitalization, prior to discharge. Now, if the non-culprit lesion seems borderline significant, maybe 60, 70, 80% angiographically, we may do, most of the time we do FFR guided management. So we'll see if it's hemodynamically significant, and it is, we'll treat accordingly. So this is the patient from the beginning of the talk. So he had a drug-eluting stent placed in the RCA, and he has, good flow, some minor CAD, but otherwise, great results. And here, he had a stent placed in the left circumflex, again, with great results.
So, Atif, I think you really did a great job. My question here to you is, with potent antiplatelet agents available, and we being very aggressive in using right anticoagulants in the cath lab, I think fixing a non-culprit artery, if you really see it's tight and it is supplying a big area, I think it's a good strategy. Do you agree with me, and what are your practices elsewhere?
So, Dr. Vashish, would you like to take that question? It's still not working.
So I think that's a very relevant question that we face in the cath lab dealing with acute MIs, and congratulations out there for a very good talk that simplifies and kind of sums up all the evidence that we have. I think if we look at all the evidence, as Atif pointed out, there are multiple issues with multiple trials, but there are practical issues seeing these patients at 3 in the morning. Oftentimes, it's not easy to say which is the culprit lesion and which is the non-culprit lesion, and sometimes there is equipoise in terms of treating. You could have a tight 90% right or a circ which presents similar fashion. But I tend to agree with you that I think if you have a culprit lesion that's been taken care of and you have a critical lesion in another artery that's otherwise easy to approach, then there is reasonable effort should be made in terms of revascularizing the non-culprit artery as well, especially when you have a higher, when you have a bigger area of myocardium at risk. For sure, if they are in cardiogenic shock, if they have intractable arrhythmias, ongoing chest discomfort, those would be the accepted reasons. But barring those, if there is a higher risk myocardium and larger area, then I think it's probably the right thing to do. What these studies don't really show in terms of stable patients, so someone who's not having chest pain, you fixed the culprit lesion and they're stable, whether fixing them right at the index procedure versus index hospitalization is less clear to me. Could you wait 2 days longer and do it prior to the discharge? And so that distinction is not available. So PRAMI trial, for example, had immediate fixing of these rather than the other trials where they allowed you to do it either in the index procedure or index admission. So I think those factors are important. And practically for us, also, sometimes 3 in the morning, you don't have their renal function available. You don't know who these patients really are. Are they going to be adherent to medical therapy? Do they have anything else going on? Do they have ongoing, requirement for anticoagulation? So it helps tease those things out if you can wait for another few days prior to the discharge. So I think those are some of the nuances that go into the decision making. But I think if it's a straightforward lesion that you know the patient well and there's no other contraindication, I think it's reasonable to go ahead and fix it at the same time.
Just to add to Dr. Vashish's point, the reason we are worried about fixing the non-culprit lesion on day 1 is at least a part of it is acute stent thrombosis. So patient with acute MI, there's actually a higher risk of thrombosing their stent just because there's so much underlying inflammation. So if you have a clear-cut lesion which you think led to MI, then just fixing that and probably doing an elective work on the other artery after a couple of days or before they leave is probably a very reasonable way to approach this. But PRAMI, as Dr. Vashish said, most of the patients in PRAMI got stent on that index day, whatever arteries had significant blockage. So that's what I think we have been doing here, and Dr. Wahid and Dr. Akbar, Dr. Kasmuddin can speak for that. But I think as long as the patient is stable after we fix the culprit, we bring them back after a couple of days and do the other stent or do the other artery.
And one other thing I might add is that most of these studies, except for PRAMI, which you might think had a very liberal definition of triple vessel disease, they had 50% stenosis. Here's a trial that was actually stopped prematurely, so it has limitations of being smaller in that regard. But most of the other trials have shown it is the need for downstream revascularization that's decreased. That's what's driven most of them. So as Atif pointed out, the data for actually MI decrement is somewhat less clear. So, which is good in a way because it allows you to, not be bound to fixing everything on the index admission. So I think that gives you the latitude to say, okay, he's going to be here for another 2-3 days. And to Anirudh's point, if you do land up into a complication with the non-culprit artery when the patient is stable post-PCI of the culprit artery, then I think you are dealing with someone who's got an acute wall motion abnormality, and now you have managed to turn grab defeat from the jaws of victory, so to speak. So I think there are nuances that should be considered prior to making that decision.
Good afternoon, everybody. My name is Jason Cohen. as Dr. Tatari said. I'm the other second-year cardiology fellow here at the Medical Center. I'm going to be discussing updates in antithrombotic therapy for complex patients. So an exciting new trial came out in the New England Journal of Medicine in 2016 called the Pioneer AF-PCI trial. Dr. Gibson and colleagues investigated outcomes of patients with atrial fibrillation undergoing PCI on various antithrombotic regimen. And I'm going to be talking about the trial a little bit later, but I actually wanted to go over a little bit of background first. As you may or may not know, there are approximately 735,000 heart attacks nationwide each year. And the mainstay of treatment is actually percutaneous coronary intervention, or PCI. This involves the use of balloons to create controlled dissections and stents to help maintain patency of the artery. And Dr. Tatari has actually gone over a little bit of this already. But it's definitely relevant to what we're doing. Afterwards, patients who've had this disruption to the endothelium and the introduction of this foreign body, this stent, they need to be protected from artery thrombosis. So we give them dual antiplatelet therapy, or DAPT, which consists of aspirin and a P2Y12 inhibitor. The current options are clopidogrel, ticagrelor, and prasugrel. A common question is, how long do we give the APT? We know that endothelialization after angioplasty or the placement of a bare metal stent takes about 28 days. We don't know exactly how long it takes with drug-eluting stents because they're actually designed to prevent or to retard neoproliferative changes. We do have some guidelines to help guide us. For patients who have stable ischemic heart disease, 1 month of DAPT for bare metal stent placement and 6 months of DAPT for drug-eluting stents is recommended. And for patients who come in with acute coronary syndrome, 1 year of DAPT is recommended regardless of whether they got a bare metal stent or a drug-eluting stent. In practice, however, we often find that we have to cut short our duration of treatments or conversely continue them almost indefinitely. Indeed, there have been a number of studies to find out the optimal length of treatment to avoid unnecessary bleeding and also to prevent late stent thrombosis. So we actually have a number of guidelines that really help just kind of give us leverage when we tailor patients' duration of DAPT to suit their particular scenario. A significant subset of patients undergoing PCI actually have atrial fibrillation, making this a pretty complex issue. About 2% of patients of the general population under 65 and 9% of the patients or general population over 65 will have atrial fibrillation. And of the 640,000 PCIs which were done in 2009, the average age was about 64.6, which kind of helps us with our numbers here. Some quick math gives us a rough number of 35,000 patients that year who had atrial fibrillation and underwent PCI. So this is not an insignificant number. This is a fair amount of our population. Like Gene Simmons here, there are between 2.7 and 6.1 million people in the United States who are living with atrial fibrillation. And the most feared and really infamous complication of atrial fibrillation is cardioembolic stroke. The standard tool we have to assess stroke risk in AFib patients is the CHADS-2 VASC score. A point is given for each of 7 patient characteristics: congestive heart failure, hypertension, age greater than 75, presence of diabetes mellitus, vascular disease, which includes coronary disease, carotid disease, and peripheral artery disease, and age greater than 65, and their female sexual characteristic. Which really is just their gender. And we give them 2 points for having a history of prior stroke. And I apologize for this slide. I think something got lost when it got transferred over. Everything got smaller. So anyway, patients who have a score of 2 or more on the CHADS-2 VASC scale should really receive anticoagulation to prevent future strokes because they are going to be more at risk. When we do have patients who have AFib and do require PCI, they are treated with a combination regimen of both antiplatelet and anticoagulant medications. These regimens can markedly increase the chances of a number of feared bleeding complications. And because I know there was a little confusion the other day, that picture up on the top left is not the brain afterwards. That's actually some melena. So. Again, this is a pretty complex issue with no clear answers, and there really are no strong recommendations to help us. There have been trials evaluating the use of anticoagulants in addition to antiplatelet medications for the treatment of acute coronary syndrome. These trials didn't specifically study patients with atrial fibrillation. They did find a significantly increased bleeding risk on these regimen. One prior study that did try to address this dilemma was the WOS trial. This trial in 2013 compared double therapy, which is an anticoagulant plus clopidogrel, with triple therapy, which is an anticoagulant plus clopidogrel and aspirin. This trial showed less bleeding in the double therapy arm, but most of that was due to a lower amount of non-major bleeding episodes. It did show that there was no significant difference in the risk for strokes, MI, stent thrombosis, or need for revascularization. The caveat to that is that this was a pretty small trial and it really wasn't powered to detect these secondary outcomes. The study, although did in part lead to a change in the recommendations for antithrombotic regimen in these patients who have AFib and need PCI. In 2009, the recommendation, which was class 2B, was for warfarin plus aspirin and clopidogrel. But in 2014, that changed to an oral anticoagulant plus clopidogrel, but not aspirin. So this really brings us back to our study of interest, the Pioneer AF PCI trial. So this was an open-label, multi-center, randomized controlled trial which sought to evaluate different combination regimens, primarily for bleeding risk. So over 2,000 patients were randomized into one of three groups. The group 1 patients were given low-dose rivaroxaban plus a P2Y12 inhibitor for 12 months. The group 2 patients received very low-dose rivaroxaban plus dual antiplatelet therapy, and the group 3 patients received dose-adjusted warfarin plus dual antiplatelet therapy. Patients in groups 2 and 3 received their P2Y12 inhibitor for either 1, 6, or 12 months, and after the 1 or 6 months, if they were in one of those groups, they subsequently were put on just their anticoagulant, depending on what group they were in, plus aspirin. The primary outcome studied was bleeding, and bleeding episodes were stratified into either TIMI major bleeding, TIMI minor bleeding, or bleeding requiring medical therapy, or medical attention. For those unfamiliar, TIMI major bleeding is any intracranial hemorrhage, drop in hemoglobin of more than 5 grams per deciliter, or hematocrit more than 15%, or fatal bleeding resulting in death within 7 days. The study showed significantly more bleeds in group 3, which was the warfarin arm, than the 2 low-dose rivaroxaban arms. The difference was driven mostly by bleeding requiring medical attention, not so much by either TIMI major or TIMI minor bleeding. The secondary outcomes measured were individual strata of bleeding, so that's the different types of bleeding, as well as the composite and individual MACE events. So while the study wasn't powered for efficacy, they did highlight that there were no significant differences in the composite of MACE events between either of the 2 low-dose rivaroxaban arms and the warfarin arm. So the current guidelines on this subject remain sparse. As I mentioned earlier, there is a weak recommendation for double therapy with oral anticoagulant plus clopidogrel, and there's also a weak recommendation for a bare metal stent to minimize the amount of time necessary on dual antiplatelet therapy along with an anticoagulant. Where does this leave us? I don't know that I can strongly endorse one regimen over another, either studied in this particular study or not. There's yet to be a strong trial that really addresses efficacy and that's really powered for efficacy. I think the best recommendations I can make are that we assess each patient individually, both for bleeding and stroke potential. And so that means, going through your CHA2-VASc, but also, maybe doing a HAS-BLED on them. You also need to try to minimize their exposure to these complex combination therapies if you can. And really, I think the biggest thing is that we all need to be having frank discussions with our patients and make sure that they understand that these medications, while they do have benefits, also come with risks and complications. So with that, I'm going to open it to questions or comments.
Thank you, Jason. That was a really comprehensive talk. I'm sure we all realize people who take care of these patients, it's a very complicated discussion sometimes with no right answer. We have a question.
Yes, Dr. Vashis, at our center, when we have this patient that have to be on triple therapy, it is a decision that we try to take as a group, also to involve our patients, because oftentimes, the patients do not understand what's happening, but just get into what their HAS-BLED score is. So I would like to know at your institution, what are you guys doing, because the guideline is a 2B. It's really a weak recommendation when people have to be on triple therapy, and where do we go from here?
That's a great question. And again, I was just talking to some of the EP colleagues in the morning and asking them about the same question that you had posed. I don't think there is a right or wrong answer. There are people who are more comfortable with keeping Coumadin with an INR which is lower and giving aspirin and Plavix triple therapy for a few months and then changing to an oral anticoagulant plus Plavix. It depends really on a lot of factors. What are the risks for the ischemic event in that patient? So let's say if somebody's had a PCI, if it's a left main PCI, or if it's multiple stents, the ischemic component of that plays into that role in terms of determining how important the antiplatelet part is. If someone's had a previous stroke with atrial fibrillation, then obviously the anticoagulation becomes an important consideration as well. I think if someone has a low CHA2-VASc score, then we would probably omit anticoagulation in those patients and just give them antiplatelet therapy. I think some of the other considerations would be what the morning talk was, like a left atrial appendage occlusion device where you can then be just limited to antiplatelets. Where I practice, there are people who have different opinions. We do get together with the patient, their families, and other primary care physicians involved in the care, because they are also the ones who we have to partner up with because they're taking care of these patients longitudinally. And there are varied recommendations. With some people would go with the newer anticoagulants and with Plavix alone. But my personal preference is that if it is a high-risk angioplasty that's been done and they are at a high risk for bleeding, then I would probably put them on triple therapy for a few months. And some people would say 3 to 6 months and then go on to just an oral anticoagulant with Plavix. If they're high risk for bleeding, then I would probably not go with triple therapy. So I think it's a very difficult decision to make as a general recommendation, but I think it's really on a case-to-case basis. One of the comments that was made today morning was also that when you decrease the dose of, let's say, rivaroxaban, is it while all these studies, including Pioneer AF, was for bleeding, they were focused heavily on bleeding, what the outcomes were. But what does it do to the ischemic risk stroke? I mean, you wouldn't give a lower dose of anticoagulation for a regular patient for stroke prevention. So are you now trading that off for this? Is it, as the speaker from today morning put it, is it like putting the occluder device half in? So, basically you're trying to decrease the risk of bleeding, but have you prevented a stroke, which is the other part of the whole equation? So, long answer, but a short summary would be that I think it's a difficult, it's an evolving target.
I'll go back to the talk from the morning, Christopher Ellis's talk. So he was talking about paroxysmal atrial fibrillation versus chronic AFib. chronic AFib, the chances of stroke is high. And in patients with paroxysmal AFib, the chances are less, even though we recommend full anticoagulation. But I'm saying having few beats of AFib once in 6 months, once in 2 months, caught somewhere on the EKG, and patient had stenting done, drug-eluting stent, I would say dual antiplatelet therapy should be enough in those patients, based on what I heard so far. Do you agree with me, having rare episodes of AFib?
I don't know.
Older
if
patients.
I don't know if I would agree or disagree, because part of the problem with the definition of paroxysmal atrial fibrillation and permanent atrial fibrillation is that the transition from one to the other is difficult to tell when it happens. The graph that was shown today morning did confirm that the paroxysmal atrial fibrillation had low risk of stroke, but it wasn't zero. There wasn't a comparison to you or I sitting here. And definitely aspirin or Plavix alone or in combination are not enough for treating atrial fibrillation. So yes, if someone has atrial fibrillation, which is paroxysmal today, I mean, does that warrant just not being treated? I don't think so. I think there should be some consideration. Yes, you have some reassurance that their overall stroke risk is lower than if it was permanent atrial fibrillation. But someone who's 85 years old and has high bleeding risk, so long as that discussion happens, look, the risk of stroke is low, but antiplatelet therapy is more important, and you might bleed. Then I think it's reasonable to then not give them anticoagulation. But that discussion has to happen. I wouldn't blanketly assume that's the case.
Because just, all the dual antiplatelet duration therapy trials, they have shown a general trend where the risk of stent thrombosis is high no matter what duration you do right after you stop the thiopyridine and when you're continuing the aspirin. The Europeans have continued to shorten the recommendation for dual antiplatelet therapy. So do we need to accept that, yes, there is a high risk of stent thrombosis, because the DAP trial even showed even if you continue it for long term, whenever you stop, there's going to be a high risk of stent thrombosis. So should we be moving towards a shorter duration and understanding that, and I don't know what's driving that risk of stent thrombosis, but whenever you're going to stop the thiopyridine component of dual antiplatelet therapy, there's going to be high risk?
It's a great question, and perhaps an off-label comment. You're absolutely right. The stents that we use in the US are also used in Europe, and some of the same stents have CE mark, which is the equivalent of what we have here in Europe. And drug-eluting stents have official recommendation of only 1 month of dual antiplatelet therapy. With regards to your comment about the DAP trial, that is just summarized by there's no free lunch. Anything that's been studied shows decreased ischemic risk the longer you're on dual antiplatelet therapy, but the bleeding risk also goes up cumulatively. The problem with DAP trial was that it had a mixture of stents and a mixture of antiplatelets. It had prasugrel and Plavix. Ticagrelor was not studied in that. And it had Taxus stents and other stents at that time, so it's an older trial. And that was exactly what you said. The longer you're on it, the bleeding risk was higher, and the ischemic risk was lower. But I think with the evolution of stents, which are now with smaller stent thickness, strut thickness, the polymers are more compatible. That stent thrombosis risk is low. In fact, if you look at the cumulative risk of stent thrombosis in stable patients in all trials, it's less than 1% is the stent thrombosis risk, and more likely to be like 0.7% to 0.5%. And that's different in the ACS patient population, where if you look at Triton TIMI-38 trial or you look at Plato trial, there the stent thrombosis risk is around 1.9 to 2%, because I think there the platelets are more activated. It's a different animal altogether. But you're absolutely right. With the newer stents, I think the battle is going to be one which will decrease the risk of having a stent thrombosis, and which one would afford a shorter duration. I think it's very easy for us as cardiologists and interventionalists to say, continue dual antiplatelet therapies. These patients are taken care of by geriatrics, by primary care physicians, and they have to deal with the bleeding part. The stent thrombosis risk falls with time, but the risk of bleeding increases with time. So I think it's a balancing act in that regard.
Hi, Hi, my
That's a
name is
neurologist asking a question, so it has to be a difficult one.
my name is Shilpi Mittal. I'm one of the stroke neurologists at Vanderbilt. So I was wondering, do you think that the dual versus triple antiplatelet anti-thrombotic regimen, that answer is a little bit, that question is a little bit answered by the dual PCI, redual PCI study that was published a couple of weeks ago in NEJM, where they used dabigatran and aspirin versus the triple therapy in patients with AFib who underwent PCI?
Yeah, I think it is parallel to what we've been saying, but I think your point's exactly right. I agree with you. That I think, the part of the problem with all the trials that have had this is just that, where the major concern that everyone has when the reason we're talking about this is bleed. I mean, none of us are here thinking, our first thoughts are not like what happens to the stroke risk, which should be also an important factor. And I think that's where the cut point comes, where we study in the Pioneer AF study, for example, there were 2 different doses which are lower. And it wasn't really strong enough to identify the ischemic differences in that trial. So I think, of course, if you can have someone who's young and who can tolerate, anticoagulation and antiplatelet, and there are patients who can, then I think that would probably be the best strategy, because one is an antiplatelet and the other is an antithrombotic, and they have requirement for both in those patients. But I think oftentimes it becomes less of science and more of an art on how you're going to deal with it.
So do you think people or interventionalists would start using the 110 milligram or 150 milligram of dabigatran along with antiplatelet regimen in future, instead of doing like warfarin, aspirin, and Plavix, like in patients with PCI acutely?
I think it makes intuitive sense. I just don't know if that's where I am headed or where everyone else is headed right away, but I think it does make intuitive sense.
Because the study results do show that the combination is better, or
Yes.
I should say non-inferior to the
Right.
triple therapy.
It is not inferior.
And especially as a stroke neurologist, we come across this question a lot more often, and we tend to ask our cardiologists, do you really feel that the patient needs triple drug regimen? Because a lot of our patients who are on anticoagulation, if we do their MRI brain, we do see, bleeding spots, like microbleeds. And we have noticed that the risk of bleeding is higher when someone is already on anticoagulation, irrespective of whether they had a stroke or not.
Absolutely. You've stated it well. I think and that is the comment I made, that, in many ways we are very short-sighted, or we put these patients on these antiplatelet therapies, and some of them are very potent now, but we don't necessarily see the ill effects of strokes or bleedings and other things that, patients who are taken care of by primary care folks and geriatrics and neurologists see. So I think you bring up a very valid point, and it's as I said, it's a difficult question to answer in terms of what you would do, but I would say, or I would humbly submit that duration needs to be shortened if you can. There's no question that being on triple therapy would lead to more bleeding, and eventually might paradoxically lead to cessation of therapy, because you might have to then, stop the other
Thank
stuff.
you so much for your answer.
Yeah.
So that was
Just to add flavor to this, I'll tell you, I've sent a patient on aspirin, Brilinta, added Coumadin, Lovenox 1 milligram per kg Q12 for 2 days. That's what I had to do in a patient with multivessel stenting and atrial fibrillation, cardioverted.
Something tells me that you're very proud of this decision, because there's a second time today you've mentioned that.
So no more questions, please. And I'm sure you can tell how I lose arguments with her at home like every time. That was my wife who was asking questions. All right, we'll move on to the next session, and really good job, Dr. Cohen and Dr. Titari. You're really smarter than I thought you were.